Hi everyone, this is our last video in this section. We're going to talk about common documentation challenges. I'll try to do this one a little quicker because a lot of this still goes over some of the information that we've already talked about. So we're going to talk about the common document mistakes that an RBT makes. They're vague subjective notes, forgetting to document during a session, backdating or batch entering data, skipping data collection during behavior, inconsistent use of measurement systems, not reporting program deviations, and failing to document caregiver communication. These errors typically happen just lack of training. Sometimes it's time pressure, sometimes misunderstanding of the importance of documentation, and then difficulty prioritizing documentation during a session. If you mess up everything else, documentation is something you just never can mess up. You really need as much training as possible on this, and you really need to prioritize this during your sessions. This is gonna really hurt the clients. It makes their treatment inaccurate. People will miss red flags that we could have helped them with. You'll fail your audits and billing issues. You create blind spots for your supervisor. I hate that when I walk into a home and the parents report all this stuff that I didn't know about. Is kind of the worst position you can put your supervisor in. There's of course some ethical and legal consequences and the loss of trust with the families and teams. I'll talk about that once we get to that slide, but we'll talk about strategies to avoid or correct these issues. So the first challenge is vague or subjective notes. So client had a bad day or didn't feel like working. Those are vague notes. It doesn't tell me at all what actually happened. And then specific descriptive notes are clients refused 4 to 5 demands and laid on the floor for 8 minutes after being told to clean up. If you feel like you're having trouble with this, ask your supervisor to create a list of vague notes and then create specific descriptive notes to match that one vague note. And that's a good exercise to practice. You want to use specific observable details to accurately capture the client's behavior in action. We need to note all of these variables: the fatigue, illness, and hunger. Any medication changes are important to let your supervisor know. Family stress and conflict. So stresses or conflicts in the client's home, that's going to affect your therapy, and any kind of environmental distractions. So noises, chaotic surroundings. Another problem that occurs is backdating or batching notes. So you forget to write notes, so you write a ton and you batch them. Writing notes days later, entering session notes after the fact will make our records inaccurate. Entering multiple days of data from memory. We can't reconstruct this stuff from memory. A person with the very best memory isn't really able to do this. And in general, it's unlikely that you have the very best memory. I mean, there's people who just are really good at that kind of stuff, but they're few and far between. If someone just has an average memory, we've shown there's literally been research on this, that reconstructing from memory, especially when other things have happened in between, is next to impossible to create a complete picture. This leads to inaccurate records and also leads to ethical violations. Timely and honest documentation is crucial, so make sure that you're taking that time to document accurately when you're writing your session notes or at the end of each session. Skipping data during behavior, and this is a very common one. Crisis or problem behavior distracts from data collection. So you're just overwhelmed to track anything. There are times when this happens. When you are calm, at whatever point when you're now calm and okay, you want to just write down everything that you can, even if you don't have a data sheet, even if you don't have a session note sheet, the sheet that you were tracking. Just write everything you can, and it should be the same day. But there are situations where it's impossible to take data. Do not take data and instead make yourself or a client safe. First we make ourselves or our client safe, and then we would take the data. As you get better at taking data, this should become easier for you. Keep that in mind and try your best to, at least when you're in a calm state, write down as much as you possibly can, and also start practicing this with more mild behaviors and see if you can take the data when the behavior is occurring. Inconsistent measurement. So a lot of people change behavioral definitions, like a tantrum is this, and now we make it a little bit different because it makes sense, right? You're looking at the tantrum and like, this is a better definition, so you start utilizing that. Your I don't want to say opinion, but your thoughts on a correct behavioral definition is very important, but you can't change it. You can tell your supervisor, like, this is what you're seeing, and this is why this behavioral definition might not be right, and have them change it, but you can't change it yourself. Even if you feel like the behavioral definition is off, that's fine. You continue to use it and you communicate that to your supervisor. And so same like for getting the operational definition, the time-bound part of it, the onset, the offset, you have to remember a lot, and it might be useful to always have it with you. That's how I've done it in the past. Misinterpreting data, mixing up trial by trial and first trial data can lead to incorrect conclusions. If you move to an interval system from a duration can cause a lot of trouble. Failing to document program deviation. A lot of times these happen and you don't realize till later, but if you realize it in the moment, immediately document it. Running the wrong target. So that happens a lot. You forgot we mastered red, so you run red when we're supposed to run red. Skipping programs due to client dysregulation. That's okay to do. You can pause the program because of the state, but you need to document it. You just always have to document it. And then adjusting prompt levels. A lot of this we might just do naturally, especially those who have worked with kids in the past. You already have a natural way of prompting someone you're working with. If you were an instructional aide, if you were a teacher, if you're a parent, if you babysat, you have a way of prompting. You've learned it. It works for you. For most of the kids you've used, it worked. You're going to bring that to this job, and you need to take a step back and try to stop that right now, because that's a prompt and we need to document it. And how you prompt is going to change. You can't just resort to this way that you've always prompted, which for 90% of people, it's just verbal. So we're just verbally prompting people. Take a step back and try to not do that anymore, so you can use the prompt level in the program and document that. And if you accidentally add in prompts, that's okay. It's not the end of the world. We just need to document it. Improving client and family communication. No record of parent communication. So not updating about the parent communication, and then your supervisor walks in and the parent's like, this tells them all this stuff they never heard. Worst situation ever. Behavioral concerns at home and changes not documented. The request from the family never shared with the supervisor. That's a big problem. Even things like therapy is going great, but we're seeing an increase in this during dinner time. That needs to be communicated. That's a behavioral contrast, most likely. Your supervisor needs to know about it so that we can address it. Make sure you log the reports objectively. You're going to state parents reported, not that the client slept poorly last night and had a doctor's appointment earlier today. If you observed them sleeping poorly, if you were there during the night, which I hope does not happen. We should not be at a client's house at night. Occasionally, you could get a job in some sort of group home, and then you might be the one around when the learners are sleeping. But that's the only scenario I would see something like that happening. But you're not going to see whether they slept well or not. You're just not. So you have to put parent reported. We're not saying the parent's wrong. They're probably right. I know when my kids sleep well and when they don't. I'm very clear on that, and I am objective about that. Most parents are. But we have to still write it as reported. If you went with the parent and the child to the doctor, you could report they had a doctor's appointment, but otherwise you would have to put parent reported. Impact of poor documentation, inaccurate treatment, lack of documentation leads to misdiagnosis and inappropriate treatment. We'll miss red flags. So if there's no comprehensive note, we'll miss all the behavioral changes that we could address and help the family and the learners with. You're going to fail your audits and billing issues, and the insurance or whatever your funding source is. There's a lot of data audit. typically with most of them. And so we want to show that we're compliant with our data collection requirements. If we're not doing that, we're going to fail that audit, which can cause lots of trouble for your company. You create blind spots for your supervisor, which is really difficult to deal with. Trust me, you want to have this positive relationship with the supervisor. It's very hard for us to be positive when we walk into places and people give us all this information that you should have given us. So just keep that in mind. And you want this positive relationship where they help you develop your skills and you spend quality supervision time together and both help each other in different ways. And that just can't happen when that's going on. Ethical and legal consequences. Poor documentation exposes the organization to liability and undermines professional integrity and loss of trust with the families or teams. So loss of transparency and well-documented care can damage relationships. So this is how we're going to improve our documentation. First, we can use checklists or templates. Pre-made forms can help with this. You want to track notes in real time, record observations, behaviors, or sessions on a clipboard or with a device during the session. Before every session, review your operational definitions. Even if you've done it tons of times, it still really helps. And then schedule time for post-session cleanup. So set aside 5 minutes at the end. I really think that should be 10 or 15 to complete documentation and organize materials. If that's not happening for you for paid time, talk to people about it. You should have a paid 10 to 15 minutes to organize things and document things. Seek feedback from supervisors. So request reviews of your documentation. Say like, look, this is how I did it. This is how I reported the increase in behavior this session. Is that how you want me to do it? Is that the best way? Can you give me feedback on that? We're done with the documentation module, which is kind of dry material, but super important. And so we're going to go on to our ethics and professionalism, and then you will be completed with the course. Primarily, there's just a little bit after that. Thank you.